Hello, I'm Christopher Richlin, and I'm going to discuss today the impact of TNF inhibition on structural progression in ankylosing spondylitis. In rheumatoid arthritis, structural damage is primarily catabolic. By that I mean that bone destruction mediated by osteoclasts driven by the rank TNF pathway leads to bony resorption that is not matched by new bone formation. In contrast, an ankylosing spondylitis is primarily an anabolic disease whereby inflammation coupled with biomechanical factors leads to the production of new bone, and this new bony apposition builds up and forms syndesmophytes in the skeleton, and in the peripheral skeleton you see anthesophytes and also osteophytes. A question that has arisen is whether or not blocking with anti-TNF agents can actually inhibit new bone progression in ankylosing spondylitis. To date, there are 3 studies using anti-TNF agents which have shown that these agents over a 2-year period are not effective at preventing new bone formation. Now, this may seem to make sense because we know that TNF inhibits new bone formation by multiple different mechanisms. But recent imaging studies have shown us some ideas as to why TNF may have some altering effects on new bone formation. So shown in this slide on the left is vertebra, which as you see osteitis or inflammation shown on the left. With treatment with TNF antagonists, there develops fatty infiltration. And after this fatty infiltration phase, can move into 2 different outcomes. The first is complete resolution of the fatty infiltration. The other is a formation of a syndesmophyte, and this is what happens in many patients treated with TNF antagonists over a 2-year period. We know this from a study which compared golimumab and placebo, and we see here in this study at week 14 that those patients that were treated with golimumab had higher degrees of fatty infiltration compared to placebo. When you look at week 104 and the patients were switched over from placebo to golimumab, the fatty infiltration levels were similar. The next question that comes on from these data is what is the molecular switch which either takes you to complete resolution or moves you on to the formation of syndesmophytes? At this point in time, we do not know what that switch is, but we do know that there are 3 pathways that lead to new bone formation, and these are things that we may want to target as we look to trying to prevent this adverse outcome in ankylosing spondylitis. So I'm going to describe these 3 pathways for you. The first is BMP, which acts through the SMAD pathways, SMAD signaling pathway, to promote osteoclast differentiation. The second is the Wnt signaling pathway, shown here, the frizzled receptor and the LRP56, which when bound by glycoproteins in the Wnt ligand family, leads to the phosphorylation of beta-catenin and subsequent osteoblast differentiation. We do know that you can inhibit the Wnt pathway through the soluble frizzled receptor protein and also the DKK1 and sclerosin, which bind to LRP56 and block new bone formation. The third pathway is prostaglandin E2, which can act to stimulate osteoblast proliferation and differentiation. And we know that you can use a variety of agents, NSAIDs, to inhibit heterotopic new bone formation and also to inhibit new bone formation, possibly in ankylosing spondylitis. So what are the potential strategies to block pathologic bone formation in ankylosing spondylitis? Well, 1, early treatment to rapidly control inflammation and prevent the molecular switch to new bone apposition is one strategy. Another is to combine anti-TNF agents with nonsteroidal anti-inflammatory medications, and there's some data to suggest that NSAIDs may block the effects of PGE2 in ankylosing spondylitis. And the third is the use of bone morphogenetic antagonists such as noggin or Wnt inhibitors such as DKK or sclerosin to block pathologic new bone formation. I'll take questions from the audience.
So Chris, knowing how well TNF inhibitors work clinically in ankylosing spondylitis, this is all interesting data, but how much do we need to worry about this in the average patient who's actually responding quite well clinically? Is this a real issue? Yeah,
Eric, I think this is a critically important question. So we know that anti-TNF agents lead to improved signs and symptoms, and in some cases even improved function. So the question is, how important is radiographic new bone formation, which occurs at various rates in various patients, going to be in the long-term clinical outcome compared to the improvement that we see with anti-TNF agents? I don't think we're going to have the answer to that until we have much longer studies, but certainly from what we've seen in terms of improving functional ability and pain, the anti-TNF agents are very effective, and it's not clear that this new bone formation is going to offset that efficacy over time.
Chris, what do you think of the quality of the evidence that nonsteroidals can truly inhibit these bony changes?
So there are two studies that have looked at the effect of nonsteroidal anti-inflammatory agents on preventing bone progression in ankylosing spondylitis. One is a study from 1976, which really looked at the effect of phenylbutazone and did show that there was a slowing of X-ray progression, not using fancy outcome measures. And the second was a study that looked at celecoxib both in a demand form and a continuous dose, and showed some improvement in continuous dose celecoxib. There are flaws with both studies, so the answer to your question is I think we need better designed studies that help us determine the effect of prostaglandin inhibition on delaying the progression of new bone formation. I think these studies are very intriguing, and we're finally learning about new bone formation, an area that's been a mystery for quite a long time. But certainly long-term studies in early disease are going to need to be carried out for us to understand the role of anti-TNF agents on preventing long-term disease progression.